What are the critical anatomical and physiological differences between pediatric and adult patients that impact resuscitation efforts? Answer: pediatric patients differ from adults in several key anatomical and physiological aspects that significantly influence resuscitation practices. Airway structure: pediatric airways are smaller and more compliant. The trachea is proportionally narrower, which can lead to increased resistance and potential for obstruction. Rescuers should use appropriately sized equipment, e.g., masks, tubes, to ensure effective ventilation. Breathing mechanics: infants and young children have a higher respiratory rate and a low functional residual capacity. They are more prone to rapid desaturation and thus high-quality continuous positive pressure ventilation is critical during resuscitation. Cardiac output: in children, cardiac output is more dependent on heart rate than stroke volume in contrast to adults. This means bradycardia in a pediatric patient can severely impact circulation. Prompt recognition and intervention, e.g., with pacing or medications, are essential. Fluid resuscitation: the smaller blood volume in pediatric patients means that fluid resuscitation protocols need to be carefully calculated to avoid overloading the heart. Thermoregulation: infants and children are more susceptible to hypothermia during resuscitation due to a higher surface area to volume ratio. Maintaining normothermia is vital. Discuss the importance of the pediatric chain of survival and its components in improving outcomes for children in cardiac arrest. Answer: the pediatric chain of survival is a crucial framework that outlines the essential steps to improve outcomes in pediatric patients experiencing cardiac arrest. It includes the following components: recognition of cardiac arrest and activation of the emergency response system. Early recognition of the signs of cardiac arrest, unresponsiveness, and abnormal or absent breathing is critical. Activation of the emergency response system ensures that advanced medical help arrives as quickly as possible. Early high-quality CPR: performing high-quality cardiopulmonary resuscitation CPR immediately improves the chances of survival. High-quality CPR includes chest compressions at the appropriate rate and depth, allowing for complete chest recoil and minimizing interruptions. Rapid defibrillation: for cases of shockable rhythms, e.g., ventricular fibrillation or pulseless ventricular tachycardia, early defibrillation is essential. Pediatric-specific defibrillation pads and appropriate energy settings should be used to ensure effectiveness while minimizing potential harm. Advanced life support: advanced interventions may include airway management, drug administration, and advanced monitoring. The PALS algorithms guide responders in the appropriate steps to take during cardiac arrest scenarios. Post-resuscitation care: after achieving return of spontaneous circulation, ROSC comprehensive post-resuscitation care is vital. This includes stabilization, monitoring for complications, and addressing potential causes of the arrest to improve outcomes. The pediatric chain of survival emphasizes a systematic approach promoting prompt action at each step, ultimately leading to better survival rates and neurological outcomes in pediatric patients. Ms. Thompson is a nurse attending a pediatric emergency when a 5-year-old boy presents with severe respiratory distress due to asthma exacerbation. What initial interventions should Ms. Thompson implement to stabilize the child, and what guidelines should she follow regarding medication administration? Answer: in the case of a 5-year-old boy with severe respiratory distress due to an asthma exacerbation, Ms. Thompson should implement the following initial interventions. Positioning: position the child in a comfortable sitting position to facilitate breathing, allowing them to lean forward. Tripod position can also help open the airway. Assess airway and breathing. Quickly assess the child's airway, breathing, and circulation. Look for signs of accessory muscle use, retractions, and cyanosis. Supplemental oxygen: administer supplemental oxygen to maintain oxygen saturation, SPO levels above 92%. Use a nasal cannula or mask depending on the child's tolerance. Bronchodilator therapy: administer short-acting beta agonist such as albuterol via metered-dose inhaler MDI with a spacer or a nebulizer. The typical dose for albuterol in children is 90180 Ag. 2 puffs from MDI every 4-6 hours is needed. Corticosteroids: if the child's respiratory distress is severe or not responsive to bronchodilators, systemic corticosteroids, e.g., prednisone, may be indicated. The typical dose is 1 mg a day, maximum 60 mg day for 3-10 days. Monitoring: continuous monitoring of vital signs and SPO is essential. Watch for any worsening of the clinical picture indicating the need for more aggressive intervention. Consideration for advanced airway management: if the child's condition deteriorates and they show signs of respiratory failure, e.g., lethargy, inability to speak, severe hypoxia, Ms. Thompson should be prepared to assist with advanced airway management, potentially including intubation if necessary. Guidelines to follow. Administer medications following established pediatric emergency protocols and guidelines such as those from the American Heart Association, AHA, and the Pediatric Advanced Life Support PALS guidelines. Always weigh the risks and benefits of medication administration, especially in young children, considering their unique physiological responses. What are the critical components of the PALS cardiac arrest algorithm, and how do they differ in the management of pediatric patients compared to adults? Answer. The Pediatric Advanced Life Support PALS cardiac arrest algorithm encompasses critical components designed to optimize resuscitation in pediatric patients. The key differences in management compared to adults are early recognition and activation, rapid identification of cardiac arrest signs, unresponsiveness, absence of normal breathing, and immediate activation of emergency services are crucial. This remains consistent with adult protocols. High-quality CPR. Pediatric CPR focuses on compression rate, 100, 120 compressions per minute, depth of compressions, approximately 1.3 of the anterior-posterior diameter of the chest, about 1.5 inches for infants and 2 inches for children. Compression to ventilation ratio, 32 for single rescuers, 15:2 for 2 rescuers. Defibrillation. In pediatric patients, the use of an automated external defibrillator aid with pediatric pads is emphasized. The energy dose is typically lower than in adults, with recommended energy levels of 2 for Jg for the first shock and up to 10 Jg for subsequent shocks. Airway management. Pediatric patients may require different techniques for airway management. The use of bag mask ventilation should be optimized, focusing on minimizing interruptions to chest compressions. In contrast, adults may often receive more advanced airway interventions earlier in the algorithm. Medications. The dosing of medications like epinephrine is weight-based. For pediatric patients, the recommended dose of epinephrine is 0.1 mg or 0.1 mg of 110, 0 solution, administered every 3-5 minutes during resuscitation. Post-cardiac arrest care. Pediatric post-resuscitation care emphasizes ongoing monitoring of vital signs, neurological status, and consideration for targeted temperature management, which may not be as prominently addressed in adult protocols. By focusing on these components tailored to pediatric physiology, the PALS algorithm seeks to improve outcomes specifically for children in cardiac arrest scenarios. Explain the significance of targeted temperature management, TTM, in pediatric post-cardiac arrest care and the protocols involved. Answer. Targeted temperature management, TTM, plays a significant role in pediatric post-cardiac arrest care, aiming to mitigate neurological injury and improve outcomes following return of spontaneous circulation, ROSC. The protocols involved in TTM include indications for TM. TTM is typically indicated for pediatric patients who remain comatose after cardiac arrest, especially those with a witnessed arrest due to shockable rhythm. It is also recommended regardless of the initial rhythm in specific clinical scenarios. Temperature goals. The primary goal is to achieve a core body temperature of 32, 34 Dic, 89.6, 93.2 Dic for 24 hours. This range has been shown to reduce metabolic demand and protect neural tissues from secondary injury. Cooling techniques. Cooling can be achieved through various methods, including surface cooling, use of cooling blankets or pads that circulate cooled water, endovascular cooling, insertion of a catheter to deliver cooled saline directly into the bloodstream can provide rapid cooling. Pharmacological agents, while not the primary method, sedatives and neuromuscular blockers may be used to facilitate tolerance of cooling. Monitoring. Continuous monitoring of core temperature is essential to ensure the patient remains within the target range. Blood pressure, heart rate, and neurological status must also be closely monitored throughout the TTM process. Rewarming protocol. After 24 hours of cooling, a slow and controlled rewarming process should be initiated to prevent rapid fluctuations in body temperature, which could exacerbate neurological injury. The recommended rate is about 0.25, 0.5 Dic per hour. Neurological assessment. Following TTM, ongoing neurological assessments are crucial to determine the patient's recovery trajectory. Assessments should include evaluating responsiveness, motor function, and brainstem reflexes. TTM in pediatric post-cardiac arrest care is associated with improved neurological outcomes and is a vital component of a comprehensive post-resuscitation strategy. What strategies should be employed to manage blood glucose levels in pediatric patients after a cardiac arrest, and what are the risks of hypoglycemia and hypoglycemia in this context? Answer: managing blood glucose levels in pediatric patients after cardiac arrest is critical due to the potential for both hypoglycemia and hypoglycemia, each carrying significant risks. Monitoring blood glucose. Blood glucose levels should be monitored frequently after ROSC. Point-of-care testing can provide rapid results, allowing for timely intervention. Target glucose levels. The target blood glucose level in post-cardiac arrest care is generally between 8015 or DL 4.4, 8.3 ml. Keeping blood glucose levels within this range can reduce the risk of further neurological injury. Managing hypoglycemia. Insulin therapy. If blood glucose levels exceed 100 mg/dL, a continuous infusion of insulin may be initiated, typically starting at 0.05-0.1 unit scale and titrated based on blood glucose monitoring. Fluid resuscitation. Administer isotonic fluids to maintain hydration, which can help mitigate hypoglycemic episodes. Managing hypoglycemia. Prompt intervention. If blood glucose levels fall below 8 mdl, immediate intervention is required. This may involve the administration of oral glucose for alert patients or intravenous extradural DW unresponsive patients. Dosage for dextrose. An initial dose of 0.51 gram of dextrose can be administered intravenously. For instance, for a 20 kilograms child, this equates to 1020 grams of dextrose 10%, 100200 ml, or dextrose 25%, 4080 ml. Education and protocol development. Develop protocols and educate staff on recognizing and treating abnormal glucose levels. Regular training sessions can enhance knowledge and readiness for intervention. Risks of hypoglycemia. Hypoglycemia can lead to increased morbidity, impair cerebral perfusion, and exacerbate neurological damage due to increased osmotic load and resultant dehydration of brain cells. Risks of hypoglycemia. Hypoglycemia can cause confusion, seizures, and further neurological compromise, particularly in patients recovering from cardiac arrest. What role does continuous EEG monitoring play in assessing neurological status in pediatric patients after cardiac arrest, and what specific findings may indicate seizure activity? Answer: continuous EEG monitoring is a vital tool in assessing neurological status in pediatric patients after cardiac arrest, as it provides real-time data on brain activity and can identify potential complications, such as seizures or non-convulsive status epilepticus. Importance of EEG monitoring. Detection of seizure activity. Continuous EEG can detect both overt and subtle seizure activity, which may not be clinically apparent. Early detection allows for timely intervention. Neurological prognosis. EEG findings can provide prognostic information regarding recovery potential. Certain patterns, such as suppression or burst suppression, may indicate poor neurological outcomes. Key EEG findings indicative of seizure activity, rhythmic or repetitive spikes, waves. These may suggest focal or generalized seizure activity. The presence of sharp waves or spikes indicates abnormal electrical activity in the brain. Status epilepticus patterns. Continuous or repetitive discharges that persist for more than 5 minutes or interictal spikes that recur frequently may indicate non-convulsive status epilepticus, which requires immediate management. Generalized spike and wave activity. This pattern can be indicative of generalized seizures and may correlate with altered levels of consciousness or behavioral changes. Focal slowing or asymmetry. Focal slowing or persistent asymmetry in the EEG may indicate underlying pathology, such as focal ischemia or encephalopathy. Management of abnormal findings. Prompt treatment. If seizure activity is detected, appropriate treatment should be initiated immediately, which may include benzodiazepines or other antiepileptic medications based on institutional protocols. Multidisciplinary approach. Involvement of neurologists, intensivists, and nursing staff is essential for managing and interpreting EEG data, particularly in complex cases. Continuous EEG monitoring is crucial for optimizing neurological care in pediatric patients post-cardiac arrest, aiding in the early detection of complications and guiding therapeutic decisions. Describe the considerations for hemodynamic support in pediatric patients after cardiac arrest, including fluid and pharmacological interventions. Answer: hemodynamic support is essential for pediatric patients after cardiac arrest, focusing on restoring and maintaining adequate circulation and perfusion to vital organs. The considerations for hemodynamic support include initial assessment, assess vital signs including heart rate, blood pressure, and perfusion status, monitor for signs of shock such as altered mental status, cold extremities, and delayed capillary refill. Fluid resuscitation. Isotonic crystalloids. Initial fluid resuscitation typically involves administering isotonic crystalloid solutions Normal saline or lactated ringers at a bolus of 20 kg. This can be repeated based on the patient's response and ongoing assessment. Monitoring fluid responsiveness. Evaluate response through improvement in blood pressure, heart rate, and perfusion. If the patient is not responding adequately, consider further boluses or alternatives. Pharmacological interventions, inotropes and vasopressors. If hypotension persists despite adequate fluid resuscitation, pharmacological support may be necessary. Common agents include dopamine. Dosing varies based on desired effects. Low doses 1,5 mg may enhance renal perfusion. Moderate doses 5,10 mg improve cardiac output, while high doses 10 mg can induce vasoconstriction. Epinephrine administered in cases of severe hypotension. Typical dosing is 0.11 mg titrated to effect based on hemodynamic response. Norepinephrine, often preferred in cases of shock, initiate at 0.05–0.1 mg and titrate based on blood pressure and organ perfusion. Monitoring. Continuous monitoring of vital signs, cardiac output and urine output is essential to assess the effectiveness of hemodynamic interventions. Adjusting interventions. Interventions should be adjusted based on the patient's dynamic response. If fluid overload is suspected, indicated by signs of pulmonary edema or worsening respiratory status, diuretics may be considered. How does post-cardiac arrest syndrome, PCAS, manifest in pediatric patients, and what strategies can be employed to prevent complications associated with it? Answer. Post-cardiac arrest syndrome, PCAS, refers to the complex pathophysiological changes that occur after a patient has achieved return of spontaneous circulation, ROSC, following cardiac arrest. In pediatric patients, PCAS can manifest in several ways. Neurological impairment. Following cardiac arrest, children may experience varying degrees of neurological dysfunction. This can include altered consciousness, seizures, and potential long-term cognitive and motor deficits. Myocardial dysfunction. Cardiac function may be impaired post-arrest due to ischemic injury, which can lead to reduced cardiac output and perfusion issues. This can further complicate resuscitation efforts and recovery. Metabolic disturbances. Children may experience metabolic imbalances, including electrolyte abnormalities, e.g., hypokalemia, hypomagnesemia, lactic acidosis, and blood glucose fluctuations. These disturbances can complicate the clinical picture and must be monitored closely. Multi-organ failure. PCAS can lead to multi-organ dysfunction, affecting the kidneys, liver, lungs, and gastrointestinal tract. Organ dysfunction is often secondary to inadequate perfusion during the arrest phase and can complicate recovery. Strategies to prevent complications. Early recognition and intervention. Early identification of signs of neurological impairment, cardiac dysfunction, or metabolic disturbances is critical. Implementing a systematic assessment can facilitate prompt intervention. Supportive care. Ensuring adequate ventilation, oxygenation, and hemodynamic stability is vital. Continuous monitoring of vital signs, neurological status, and laboratory values is essential. Neuroprotective strategies. Consider targeted temperature management, TTM, to mitigate neurological injury. The use of sedatives and neuromuscular blockers may also be indicated to prevent seizures and manage agitation. Nutritional support. Initiating enteral nutrition early can help support organ function and overall recovery. Monitoring for gastrointestinal tolerance is essential. Multidisciplinary approach. Collaborate with a team of specialists, including intensivists, neurologists, cardiologists, and nutritionists, to address the multifaceted needs of the patient effectively. A scenario where Mr. Thompson's child suffers a cardiac arrest and successfully achieves ROSC. What immediate steps should be taken in the post-resuscitation care phase, and what key assessments should be prioritized? Answer. In the scenario where Mr. Thompson's child has achieved return of spontaneous circulation, ROSC, after cardiac arrest, the immediate steps and key assessments in the post-resuscitation care phase include stabilization, airway management. Ensure the airway is patent and provide supplemental oxygen as necessary to maintain adequate oxygenation. Consider advanced airway interventions if the child is unable to maintain their airway. Ventilation support. Initiate mechanical ventilation if the child is not adequately breathing or if there is evidence of respiratory distress. Aim for an appropriate tidal volume, approximately 6–8 mAg, and adjust ventilatory rate based on clinical needs. Hemodynamic monitoring and support. Continuous monitoring. Initiate continuous monitoring of vital signs, heart rate, blood pressure, oxygen saturation, fluid resuscitation. Administer isotonic crystalloid fluids, e.g., normal saline, a bolus of 20 Ag to manage potential hypovolemia. Repeat based on clinical response. Pharmacologic support. If hypotension persists after fluid resuscitation, initiate inotropes or vasopressors as indicated, e.g. epinephrine or norepinephrine. Neurological assessment. Evaluate consciousness level. Assess the child's level of consciousness using the Glasgow Coma Scale (GCS) and check for responsiveness to stimuli. Motor function assessment. Evaluate motor responses to assess potential neurological deficits, looking for any focal weakness or abnormal posturing. Laboratory and imaging studies. Obtain laboratory tests. Draw blood for glucose levels, electrolytes, renal function tests, and lactate levels. Correct any identified abnormalities promptly. Consider neuroimaging. Depending on the child's clinical status and history, consider obtaining neuroimaging, e.g. CT MRI, to evaluate for potential brain injury. Targeted temperature management, TTM. Implement TTM protocol. If indicated, initiate TTM to maintain a target temperature of 32-34 for 24 hours to protect against neurological injury. What is the primary difference between pediatric and adult airway management, and how does this impact the approach to endotracheal intubation in pediatric patients? Answer. The main anatomical differences between pediatric and adult airways include a smaller airway diameter, a larger tongue relative to the size of the mouth, and a floppy epiglottis. These differences make pediatric airway management more challenging and require specific techniques to ensure successful intubation. Smaller airway diameter. The pediatric airway is proportionally smaller and more susceptible to obstruction from swelling, mucus, or foreign bodies. Larger tongue. The larger tongue increases the risk of airway obstruction, necessitating the use of airway adjuncts such as an oropharyngeal or nasopharyngeal airway. Floppy epiglottis. In children, the epiglottis is more angled and floppy, making visualization during laryngoscopy more difficult. A straight blade laryngoscope is often preferred for better control and visualization of the vocal cords. When performing endotracheal intubation in pediatric patients, it is essential to use the correct size of equipment, e.g. smaller endotracheal tubes. Monitor sedation and paralytic doses carefully for RSI and confirm tube placement with capnography and chest rise. Failed intubations may require the use of alternative airway devices such as a laryngeal mask airway LMA or a supraglottic airway device. Sarah, a 5-year-old girl, presents to the emergency department with a suspected foreign body airway obstruction. She is conscious but showing signs of respiratory distress with stridor and cyanosis. What immediate steps should the healthcare team take to manage Sarah's airway, and what are the considerations for managing foreign body obstructions in pediatric patients? Answer. In Sarah's case, the healthcare team should follow the pediatric foreign body airway obstruction algorithm. Assess for severity. As Sarah is conscious but in distress, immediate assessment of her ability to breathe, cough, and make sounds is crucial. Positioning. Place her in a position of comfort, typically sitting up, to avoid further airway compromise. Basic maneuvers. Encourage Sarah to cough forcefully if she can. This may help expel the foreign body. If she cannot cough effectively and her airway becomes more obstructed, perform back blows and chest thrusts for a child of her age. If Sarah becomes unconscious, initiate CPR with chest compressions and attempt to visualize and remove the foreign body. For severe obstruction, consider rapid sequence intubation, RSI, if the patient deteriorates. But remember that children's smaller airways increase the risk of complications. Intubation should only be attempted if less invasive measures fail. During bag valve mask (BVM) ventilation on a 2-year-old child, what are the essential techniques and adjustments needed to provide effective respiratory support? Answer. Effective BVM ventilation in pediatric patients requires several critical adjustments. Two-person technique. One rescuer maintains the mask seal and positions the airway using either the head tilt, chin lift, or jaw thrust maneuver, while the second rescuer operates the bag to deliver breaths. Appropriate mask size. Ensure the mask fits properly to create an adequate seal around the mouth and nose without covering the eyes. Ventilation rate. Deliver breaths at a rate of approximately 20 breaths per minute, 1 breath every 3 seconds for infants and toddlers. Oxygen flow rate. Adjust the oxygen flow rate to 1015 Lmin to ensure adequate oxygenation. Avoiding excessive ventilation. Overventilation can cause gastric distension and reduce the effectiveness of ventilation, leading to a decreased return of blood to the heart. Care should be taken to provide only enough air to see chest rise. Continuous monitoring of oxygen saturation and clinical signs of ventilation efficacy, e.g. chest rise and auscultation, is necessary. What are the common causes of failed intubation in pediatric patients, and what are the next steps in managing such cases? Answer. Common causes of failed intubation in pediatric patients include improper positioning. The pediatric airway requires precise positioning due to anatomical differences. The sniffing position, slight neck extension, is often ideal. Inadequate equipment size, using an endotracheal tube or laryngoscope blade that is too large or too small can result in failed intubation. Swollen airway conditions like croup or epiglottitis can cause airway edema, making visualization and insertion of the tube difficult. Inexperienced technique. Pediatric intubation is more challenging, and inexperience can lead to improper technique and failed attempts. If intubation fails, the following steps should be taken. Reattempt intubation with a smaller tube or reposition the patient. Consider using a supraglottic airway device, e.g. laryngeal mask airway, as a bridge to securing the airway. Use capnography and auscultation to confirm the correct placement of the airway device. If all methods fail, consider an emergency cricothyrotomy. That this is rare in pediatric patients due to anatomical challenges. Mr. Thompson's 8-month-old infant, Daniel, suddenly begins to exhibit severe respiratory distress at home, with audible wheezing and no visible signs of obstruction. After calling emergency services, what should the paramedics prioritize during their arrival, and what pediatric respiratory support steps should be followed based on Daniel's presentation? Answer: upon arrival, paramedics should prioritize assessment and stabilization of Daniel's airway, breathing, and circulation. EX. In a case like this where wheezing is present, the most likely cause is bronchiolitis or asthma rather than a foreign body obstruction. The paramedics should assess respiratory rate and effort. Look for signs of hypoxia, cyanosis, or altered mental status. Administer oxygen. Use a non-rebreather mask or nasal cannula to provide high-flow oxygen. Administer nebulized bronchodilators, e.g. albuterol, if bronchospasm is suspected. If Daniel's condition worsens, consider BVM ventilation to assist in breathing while preparing for possible intubation. Monitor for complications such as pneumothorax and ensure adequate ventilation until arrival at the hospital. The emergency team should follow protocols for pediatric respiratory failure, ensuring Daniel is adequately oxygenated and ventilated. Explain the significance of positioning the pediatric patient during airway management and describe the specific maneuvers that should be employed to optimize the airway. Answer: proper positioning of a pediatric patient is crucial during airway management due to their unique anatomical features, which could significantly impact airway patency. The following maneuvers are commonly employed. Sniffing position. This involves slight extension of the neck and flexion of the head to align the oral, pharyngeal, and laryngeal axes, facilitating easier visualization of the vocal cords during intubation. Head tilt chin lift. This maneuver helps to open the airway by lifting the chin forward and tilting the head back, which is effective if no cervical spine injury is suspected. Jaw thrust maneuver. This is particularly useful in cases of suspected spinal injury. It involves thrusting the jaw forward without tilting the head, which helps to maintain airway patency without further compromising cervical stability. In infants and toddlers, due to their relatively larger heads and shorter necks, the padding under the shoulders may also be necessary to achieve optimal positioning. Proper positioning not only enhances visualization during intubation but also minimizes the risk of airway obstruction and improves ventilation efficacy. A 3-year-old boy named Ethan is brought to the emergency room after experiencing an asthma attack triggered by exposure to allergens. He is exhibiting wheezing and increased work of breathing, and the physician decides to administer nebulized medications. What are the critical considerations in the administration of nebulized medications for pediatric patients like Ethan, and what steps should be taken during this process? Answer: when administering nebulized medications to pediatric patients like Ethan, several critical considerations must be addressed. Medication selection. Commonly used nebulized medications include bronchodilators, e.g. albuterol, and corticosteroids, e.g. budesonide, to manage asthma symptoms. Ensure the appropriate medication and dosage for Ethan's age and weight. Nebulizer setup. Ensure that the nebulizer is functioning correctly and that the mask or mouthpiece fits well to minimize medication loss. Use an oxygen source to drive the nebulizer, ensuring the flow rate is sufficient, usually 6-8 Lmin. Positioning. Position Ethan comfortably, preferably sitting up, to facilitate breathing and enhance medication delivery. Monitoring. Continuously monitor Ethan's respiratory status, including heart rate, respiratory rate, and oxygen saturation. Assess for signs of improvement or deterioration. Duration of treatment. Nebulization typically lasts around 10-15 minutes. Ensure Ethan is able to complete the treatment without distress. Describe the indications and contraindications for the use of oropharyngeal and nasopharyngeal airways in pediatric patients. Answer: oropharyngeal and nasopharyngeal airways are essential adjuncts in managing the airway of pediatric patients. Oropharyngeal airway indications: unconscious patients without a gag reflex to prevent airway obstruction, situations where mask ventilation is required. Contraindications: conscious patients or those with an intact gag reflex, as it may induce vomiting or airway obstruction, suspected trauma to the oral cavity or mandible. Nasopharyngeal airway indications: patients who are conscious or semi-conscious and may have an intact gag reflex. Situations where oropharyngeal airways cannot be used due to oral trauma. Contraindications: suspected skull base fractures, which could lead to intracranial placement, coagulopathy, or significant bleeding disorders due to the risk of epistaxis. In both cases, sizing is critical. The airway should be appropriately sized based on the patient's age and anatomy, with the correct length reaching from the nostril or corner of the mouth to the angle of the jaw. What are the key considerations when managing a pediatric patient with suspected epiglottitis, and what steps should be taken to ensure safe airway management? Answer: managing a pediatric patient with suspected epiglottitis requires careful consideration due to the potential for rapid airway obstruction. Key considerations include avoiding agitation, minimize anxiety and distress, as agitation can exacerbate airway swelling. Maintain a calm environment. Do not examine the throat. Direct visualization of the throat can trigger spasm and further obstruction, hence avoid unnecessary examination. Positioning: keep the patient in a comfortable position, typically upright, to promote airway patency and reduce respiratory distress. Secure airway: have resuscitation equipment readily available, including a back mask device, endotracheal tubes, and airway adjuncts. Be prepared for possible intubation. Administer oxygen. Provide supplemental oxygen to ensure adequate oxygenation using a non-rebreather mask if the patient is stable enough. Consider antibiotics and steroids. If epiglottitis is confirmed, early initiation of intravenous antibiotics and corticosteroids can reduce inflammation and treat infection. Consultation: engage an otolaryngologist or pediatric intensivist for guidance on managing the airway and potential intubation. Explain the principles behind using capnography for confirming endotracheal tube placement in pediatric patients. What specific findings indicate correct placement, and what actions should be taken if the capnography results are abnormal? Answer: capnography is an essential tool for confirming endotracheal tube placement in pediatric patients by measuring the concentration of carbon dioxide, CO in exhaled air. The principles behind its use include end-tidal CO measurement. A properly placed endotracheal tube in the trachea will allow CO to be detected in exhaled breath. Normal end-tidal CO values range from 3.5–4.5 mHg. Correct placement indicators: color change. In colorimetric capnometers, the indicator will typically change color G from purple to yellow if the tube is correctly placed in the trachea. Consistent waveform. A consistent capnography waveform should be observed, showing a normal rectangular shape with a flat plateau during expiration. Normal findings: no CO detected. If there is no CO detected, it may indicate misplaced tube esophagus or inadequate ventilation. Low CO levels. This may suggest hypoventilation, poor perfusion, or problems with the ventilation equipment. And actions if abnormal: reassess tube placement. Immediately check the tube's position. If in doubt, reposition and reattempt ventilation. Ventilation assistance. If the tube is incorrectly placed, provide BVM ventilation and prepare for reintubation. Consider other interventions. If there are signs of respiratory failure or hypoxia, initiate appropriate resuscitation measures, including possible use of a supraglottic airway device. Capnography is a vital aspect of confirming endotracheal tube placement and guiding further interventions in pediatric advanced life support scenarios. What is the importance of the AVPU scale in assessing pediatric patients during the initial evaluation? Provide a detailed explanation of each component. Answer: the AVPU scale is a rapid assessment tool used to evaluate a patient's level of consciousness, which is crucial in emergency situations. It stands for alert. The patient is fully awake and responsive to their environment. B. Verbal. The patient responds to verbal stimuli but may not be fully alert. P. Pain. The patient responds only to painful stimuli, indicating a lower level of consciousness. Unresponsive. The patient does not respond to any stimuli, which is a critical condition. Understanding a patient's level of responsiveness can help determine the urgency of intervention. For example, a patient who is unresponsive may require immediate airway management and advanced life support protocols. This approach aligns with the guidelines set by the American Heart Association for Pediatric Emergency Care, emphasizing the need for prompt identification of life-threatening conditions. Mr. Thompson's 7-year-old daughter Emily has suddenly developed labored breathing and a wheezing sound. As a caregiver, what initial steps should Mr. Thompson take to assess her condition? Answer: Mr. Thompson should follow these steps to assess Emily's condition. Scene safety. Ensure that the environment is safe for both him and Emily. Initial assessment. Airway. Check if the airway is open and clear of obstructions. Breathing. Observe the respiratory rate, effort, and any abnormal sounds, e.g. wheezing, stridor. Circulation. Check for signs of poor perfusion, e.g. capillary refill time, skin color, disability. Use the AVPU scale to determine her level of consciousness. Focused history. Gather information on her medical history, including any known allergies, medications, or recent illnesses. If Emily's condition appears severe, e.g. difficulty breathing, altered consciousness, Mr. Thompson should call for emergency medical services immediately and prepare for potential advanced airway interventions such as nebulized bronchodilators if available. How can capillary refill time be used to assess circulation in pediatric patients? What is the normal range, or what could deviations indicate? Answer. Capillary refill time is a quick and effective method for assessing peripheral circulation in pediatric patients. The procedure involves pressing on a fingernail or the skin until it blanches, and timing how long it takes for color to return after releasing the pressure. Normal range. A capillary refill time of less than 2 seconds is generally considered normal. Deviations. Prolonged refill 2 seconds may indicate poor perfusion due to conditions like shock, dehydration, or significant blood loss. Very rapid refill 1 second might suggest hyperemia or increased blood flow due to conditions like fever or anxiety. The American Heart Association (AHA) guidelines stress the importance of using capillary refill time in conjunction with other assessments like heart rate and blood pressure to get a comprehensive view of a patient's circulatory status. What are the key differences in respiratory assessment techniques between pediatric and adult patients? Answer. The respiratory assessment for pediatric patients differs from that of adults due to anatomical and physiological variations. Key differences include anatomy. Pediatric patients have smaller airways, making them more susceptible to obstruction. Technique. In children, auscultation may require different positioning to effectively hear breath sounds, and caregivers often use a pediatric stethoscope. Assessment of work of breathing in children includes observing retractions, intercostal, supraclavicular, and nasal flaring, which are less commonly assessed in adults. Normal values. Pediatric respiratory rates are higher than adults, with newborns typically having rates of 3.0-6.0 breaths per minute compared to adults 1.2-2.0 breaths per minute. Guidelines from the AHA highlight the need for specialized techniques and an understanding of pediatric physiology to ensure accurate assessment and timely intervention. In the context of PALS, explain the significance of using arterial blood gas EBAG analysis in pediatric patients. What parameters are most critical to evaluate? Answer. Arterial blood gas EBAG analysis is crucial for evaluating a pediatric patient's respiratory and metabolic status, especially in critical situations. Key parameters include pH, indicates acid-base balance. A normal pH is typically between 7.35 and 7.45. POCO measures carbon dioxide levels. A normal range is 3.5-4.5 mg. Elevated levels may indicate hypoventilation or respiratory failure. POW reflects oxygenation status. A normal range is 7.5-10 or Ag. Low levels suggest hypoxemia. ATO indicates metabolic status. A normal range is 2.2-2.6 meckel. Normal levels may signify metabolic acidosis or alkalosis. Understanding these parameters helps healthcare providers make informed decisions regarding interventions such as oxygen therapy, mechanical ventilation, or bicarbonate administration. The AHA guidelines emphasize integrating a EBAG analysis with clinical assessments to tailor treatment effectively. What are the major considerations in the focused history and physical examination of a pediatric patient using the SAMPLE method? Answer. The SAMPLE method helps clinicians systematically gather important information during the assessment of pediatric patients. It stands for S signs, objective findings noted during the assessment, such as cyanosis or wheezing. Allergies, important to identify any allergies to medications, foods, or environmental factors. Medications, understanding current medications can help prevent adverse drug interactions. P. Past medical history, information about chronic conditions. E.g. asthma, diabetes, informs the treatment plan. L. Last oral intake. Knowing when the child last ate or drank is essential for determining the need for interventions, especially before anesthesia. Events leading up to present illness, injury. Contextual information can guide diagnosis and treatment. Using the SAMPLE method aligns with guidelines from the AHA facilitating a thorough understanding of the patient's condition and appropriate response measures. Describe how to perform a rapid cardiovascular and respiratory assessment on a pediatric patient. What indicators should be prioritized? Answer: a rapid cardiovascular and respiratory assessment should be conducted as follows. Circulation, pulse quality. Assess the strength and regularity of the pulse, e.g., brachial or radial. Capillary refill. As previously discussed, perform the capillary refill test to evaluate perfusion. Heart rate. Usage specific norms to determine if the heart rate is within the normal range for the child's age, e.g., 80120 BPM for school-aged children. Respiration. Respiratory rate. Count the breaths per minute and compare to normal ranges for age. Work of breathing. Observe for signs of distress such as retractions or use of accessory muscles. Breath sounds. Listen for abnormal sounds, wheezing, stridor, or diminished breath sounds. Prioritizing these indicators ensures rapid identification of critical issues, enabling timely interventions aligned with AHA guidelines. When using chest X-ray CSAR for pediatric patients, what specific conditions or findings should clinicians be vigilant for that may indicate respiratory distress? Answer: clinicians should be vigilant for the following conditions or findings on a chest X-ray CXR that may indicate respiratory distress in pediatric patients. Airway obstruction. Signs like hyperinflation or atelectasis, infiltrates or consolidation. These could indicate pneumonia or other infectious processes. Pleural effusion. Fluid accumulation can compress lung tissue and hinder breathing. Foreign bodies. Look for evidence of aspiration, especially in younger children. The AHA emphasizes the need for a clear understanding of CXR interpretations in pediatric patients, as timely diagnosis can be critical for initiating appropriate interventions. What are the implications of recognizing hypothermia or hypothermia in pediatric patients, and how can these conditions be addressed in an emergency setting? Answer: recognizing hypothermia and hypothermia is critical, as both conditions can lead to severe complications. Hypothermia, defined as a body temperature below 35 Dec, 95 Dec. It can lead to bradycardia, decreased metabolism, and impaired respiratory function. Treatment includes gradual rewarming using blankets, warm fluids, monitoring vital signs closely. Hypothermia, typically defined as a body temperature above 38.5 Dec, 101.3 Dec. It can result in heat exhaustion or heat stroke. Addressing hypothermia involves immediate cooling measures, removing excess clothing, using cool compressors, hydration with fluids, oral or intravenous, depending on the severity. These practices are in accordance with guidelines from the AHA, which emphasize early recognition and intervention to prevent progression to life-threatening states. Explain the role of laboratory diagnostics in the management of pediatric patients undergoing PALS. How do these diagnostics assist in clinical decision-making? Answer: laboratory diagnostics play a crucial role in managing pediatric patients during PALS by providing objective data that informs clinical decision-making. Key diagnostics include arterial blood gas ABG, helps assess oxygenation, ventilation, and acid-base balance, guiding interventions like supplemental oxygen or intubation. Complete blood count CBC can identify infections, anemia, or other hematological issues. Electrolytes and metabolic panel. These tests can reveal imbalances that may affect cardiac and respiratory function, such as hypokalemia, which can lead to arrhythmias. The AHA guidelines advocate for the integration of laboratory results with clinical assessments to develop a comprehensive treatment plan tailored to the patient's specific needs, ultimately improving outcomes in pediatric emergencies.